The next speaker again is Dr. Divya, and she'll now be speaking on vitreoretinal interventions in ectopia lentis.
So now we have seen the anterior segment management for subluxated lenses. So now when a VR person should intervene. So when there is a complete subluxation into the vitreous cavity, obviously a VR person only should intervene. And some cases when there is, especially in microspherophakia, when the lens is like kind of little unstable and not sure while doing the surgery, it might go posterior, or somebody is not comfortable in putting an IOL in the same sitting, so in those cases. And so anywhere when there is an indication for surgery, and especially when it is quite posterior, then a VR person should intervene. So the options is like it is a pars plana route, which is a lensectomy, and some cases we even tend to do from an anterior route, especially if the lens is quite anterior, and especially in syndromes like Trabulsi, where the risk of scleral thinning and exposure would be more, and the other techniques have already been mentioned. And whenever there is an associated retinal detachment or anything, then again a VR approach is needed. So IOL option already has been mentioned. And as I mentioned about the age, the IOL preferably when you are intervening to put in the same sitting when at least the child is above 5 years of age. I have put the youngest age which I put was 3.5 years in a child with the bilateral subluxation. That was siblings, actually, both the siblings. But I would recommend that at least to 5 years of age. So I'll just discuss a couple of cases so that the importance of why to intervene and manage these cases. So this was a 6-year-old girl who had presented initially at 2010. And that time her vision was 20/50 and both eyes with a -10 in right eye and -8 in the left eye. So this is a timeline of how that kid has gone. So that time 2010 actually the IOP was controlled with 2 medications, and then on follow-up the IOP was on borderline. They kept on increasing the number of AGMs, and then in 2012 the IOP was still not controlling with the maximum medication. So then finally in 2015 the cup disc ratio kept on increasing from 0.3 to 0.7 with maximum medication. The IOP was 22 and 28 in the left eye. Then decided that okay, the child can be taken up for trabeculectomy first. So the child underwent trab with MMC in the left eye. And on 2 weeks follow-up, the child gave a trivial history of trauma, and this was like the iris had prolapsed into the ostium, and it was blocked, and the IOP had gone high. So then this kid was sent to us for a vitrectomy. So then this is a surgical video where the child underwent. So those times I used to do like for clear lens extraction, subscleral sclerotomy lensectomy. Means like I never used to make a separate port for a vitrectomy. So because this was glued IOL, we exteriorized the haptic through the same port where under the flap where you exteriorize the IOL. So through the same port I used to do the lensectomy and vitrectomy. So only 2 ports with an AC maintainer. So this is how the lensectomy was completed, and in all these cases I do a complete vitrectomy, and any areas of lattice degeneration or any weakness, then I do a barrage laser also in these kids because they need a long year of follow-up. And so this was an initial glued IOL technique which I used to do these 4 kids. So after this, the right eye, because again it was on maximum medication and the cup disc ratio was increasing, so so for the left eye initial trab was done, and then when it was not controlled, it was sent for vitrectomy. So now for the right eye they sent in the beginning itself to us for a vitrectomy and glued IOL. So I did a pars plana lensectomy, vitrectomy and glued IOL. So now IOP progression over the time, you can see post surgery it has come down, and now the child is on only 2 medications, and this is the cup disc ratio progression. So till the time of surgery it was like increasing to up to 0.7, and after that it got controlled. And so in the final outcome, so initially the child was having -10 and -8, and she was improving only to 20/50. Now with the after the surgery with IOL, she is 20/20 with the best corrected visual acuity. IOP is controlled with 2 medications. So this is the importance, like you should intervene at the right time. And many cases sometimes initially may not be trapped because the lens might be a culprit in these cases. So we need to assess whether that is why I mentioned that gonioscopy need to be done, because some of these cases might have an congenital angle anomaly. So in those cases, and some cases where delayed intervention, where it has already caused a ankle synovial closure, then even after you do a lensectomy, vitrectomy, these kids might require an AGM to be continued or a trap procedure or a glaucoma device later. So it is gonioscopy which is very important. If whenever before intervention, if you can do that, and whenever the lens is the culprit, if you tackle the lens many a times, the IOP might get controlled to a limit where the refractive error has been, like, child has been tolerating well. So in many of those kids, you see that after intervention, the visual acuity also improves and the child's quality of life also improves. This is a case too. This is actually siblings. Both of them had subluxation, and both the kids were under follow-up for 5-6 years, and this one of the kid I am presenting. So this over a follow-up of 5-6 years. Now when I saw the kid was like having 636 in the right eye with -10, and the left eye was -14 and improving to 636. And right eye already had a scleral thinning and AC was very shallow. One PA was done at that point of time in both eyes. And when later actually this kid's sister had presented in our OPD with an acute anterior subluxation and angle closure. So that time that kid has to undergo a pars plana lensectomy. So that was the point when this kid was sent to us. So that point of time, because there was a microspherophakia, and I did a pars plana lensectomy, vitrectomy, and a flange dial for this kid. So post surgery, his left eye IOP is maintained. His best corrected acuity improved with -2 to 612, and the right eye we can't intervene now because the anterior chamber is completely flat and there is an iridocorneal touch, so it is very difficult to intervene in that eye now, and he is only counting finger close to face. So this is a left eye surgery which we did. So this time I did not do a subscleral flap incision because I was planning for a flange diol in this kit. So 3 separate sclerotomies were made. And actually supranasal, here you can see there is already a scleral thinning. So this kid might be a Trabowsi syndrome, most likely. We had asked for a genetic screening, but it's a single parent kids actually, so they won't afford all these things. So this is how the flange diol is being done. And post-op, the child is very happy. In fact, he comes to OPD smiling and very playful. So whether the lensectomy will help in this condition, so already there are published literature. So this study by Divya has shown that lensectomy alone without any IOL, have 50% of the patients the IOP reduction has happened, and even sometimes only 7% needed actually any surgical procedure. And this was one of our own publication actually, where we did lensectomy and I did glutathione in for all these kids. But this group was actually having an advanced disease and on maximum medication. So here actually, even in these kids actually, 21% over 1 year could get controlled with the surgical procedure. So surgical outcomes actually is very good, and especially both in terms of control of IOP and also in terms of best corrected visual acuity. So tailoring a vitreoretinal surgery in ectopia lentis like a timely surgical intervention, it saves both like in a long-term complications like a glaucoma. Second thing is the refractive error the child is having, but we need to individualize the IOL, which are the surgical procedure which need to be done in this, and a multidisciplinary care like a pediatric ophthalmologist, again because of the systemic issues with a pediatrician and a physician or an orthopedician is required in this. So thank you.
Thank you, Divya, for that wonderful talk. Do you have any problem assessing the IOL power in these children?
So usually if the kid is like less than 7 years, I reduce it from the age actually. So if 5-year-old, like I usually measure it like 7 minus 5, that is 2 diopters I reduce if I take for less than 7 years of age. And that is the only manipulation which I make actually, or sometimes 0.5 less, but usually I don't do that much.
Okay.
If time